Good morning, everyone. Welcome to the September 22nd, 2022 Subcommittee on Worker Continuation of Care, and also happy first day of autumn for those who choose to celebrate, acknowledge that fine day, and drink your pumpkin spice lattes in celebration. So with that, I'm Teresa Van Winkle. I am the administrator for MLAC. We are here to get to do our second part of continuing input from medical providers and the medical managed care organization community on a variety of issues related to the worker continuation of care. And we do have 3 members of MAC that are here, but before we introduce them and kick off input, I will open up a review of the minutes from the September 16th meeting. And Sarah, we did circulate the version with your edits, so those will be incorporated into the official minutes, the final version.
Thank you. I have no further comments. Do you, Matt?
You know, I didn't have a chance to review the minutes. Can we punt it to the next
meeting?
We can.
Oh,
okay.
yeah, we totally can. That's fine. That's fine. Okay, with that, again, we do have the 3 members of MAC that are here. We have Chair Dr. Ronald Bowman. We have Dr. Jennifer Lawler, who is a representative from the MCO community. And last but certainly not least, we have Lon Holston, who is a worker representative for MAC and is a longtime stakeholder in the workers' comp policy community. So I will turn it over to you, Dr. Bowman, if you'd like to start, that would be great.
Sure, thank you. Yeah, thanks for asking us to be part of this process. For those of you that don't know me, I'm an orthopedic surgeon in Portland. I've been chairing MAC for almost 20 years. About 80% of my practice is work comp. The MAC committee discussed, I think the issue you want some feedback on, which is time loss authorizations and specifically open-ended ones. In May of last year, 2021, I reviewed the records on that. And we discussed that for quite a while among the members. You have to realize in the MAC committee, we have a selection bias because everyone on the committee is interested in work comp, or they wouldn't be spending their spare time doing that. And a lot of the problems seem to be the occasional attendings that give some of these extended time loss benefits. Most of us, including myself, were unaware that open time loss was even allowed. Work release that says you're off work with no end to it. And we discussed that for a while. Most of us thought, had a consensus that a 30-day limit is reasonable and not a hardship, particularly if for the workers who are on full-time loss, they have nothing else to do, unless there's an issue with access. The occupational medicine doctor, like Dr. Rishatili is one, in their practices, they are seeing patients on full-time loss every 2 weeks. I don't do that in my practice. We go monthly. And then light duty revisited every 4 weeks or 30 days. Is this, and I don't know if you want the feedback, is this a rule making thing or an interpretation or prepare for new legislation? Where is it?
I can take that. So we are charged as a subcommittee from MLAC. So first, thank you for your time and your willingness to bring forth your opinion and on this matter. But we believe we have a problem statement to address, and that is a continuation of care for workers' comp, and to see, because currently there's no requirement how often injured workers must see a physician or an attending or a type A provider, however you want to call them. And we're just addressing that problem statement to see if, 1, there is a problem, and 2, to come up with solutions.
Okay, and I think the MCOs, it's all in the contract language and there is some control there. So it's the non-MCO claims, I believe. And I think it is problematic if there is an open-ended work release. If you couple that with the wrong personality of worker, I see in your committee notes, I read those ahead of time, it's called doctor dodging. I've not heard that, but I like that. But it'll be harder to get the worker engaged in his or her own recovery.
This is Matt. Matt Calzia. I'm on the subcommittee, and I would have a question on that. I guess since you have an extensive experience with most of your practice involved with this, do you experience that often, or have you ever quantified how many folks just don't seem to engage with the physician, the attending?
Well, in my practice, we treat everyone the same, and we make an appointment for them for 30 days at the most, and most commonly for the next appointment. And their work release then goes from the date that I see them until the appointment is made before they leave the office. So we don't get into issues very often. If I can't remember when there's been one recently. But if we had relied on the worker to make the appointment, it could be a problem with confusion if they have an open-ended work release and they're supposed to make an appointment after they leave, but they're Hispanic or Lithuanian or some other language and not really understanding everything. It could be inadvertent, but it could lead to problems with that.
And then I do have another question, just kind of like, I guess it's sort of a hypothetical, but I would say this is a common issue is, a worker may see an attending who's a general practitioner, and then they go through steps where they may and then get referred to like an orthopedic surgeon who determines that a procedure is needed. And right now, a lot of, with orthopedic surgeons, we're looking at 60+ days from the time of acknowledging we need that procedure done to when they can actually get in and have it actually scheduled. And so in that time, the worker is kind of, they're going to have to wait for that procedure to move forward. And so the way that things are, they would have to go, and I'm asking because you have more experience, I'm not totally positive, but this idea would be they would have to just go see their attending, because that's the one who continues those time loss, right? It's not the orthopedic surgeon, it wouldn't be the consult, it would be the attending in particular. So we'd be saying, or hypothetically, then their procedure is scheduled 60 days out from when they saw the orthopedist, but we want to require that they pop in and schedule and get in to see an attending in between that. For what purpose, right? Like, yeah, we're all struggling to keep appointments flowing, and everybody's, there's not like an abundance of space and scheduling. So it seems like, for what purpose would that exist? Or they say do 8 weeks of physical therapy. It takes 2 weeks just to get scheduled for the first physical therapy eval, or however many sessions that need to be done. That could easily extend well beyond 30 days, and we could be looking at 60+, when you look at the complexities of scheduling. So I guess I'm just curious, like when we look at the realities of all of that, how does that work? Like, you're an orthopedic surgeon, so you may see it differently than an attending who's just a GP, and I'm curious if the MAC discussed those scenarios.
Well, I can tell you from my personal experience, I have a business relationship with an Ahmed clinic in Salem, and they remain the attendings, even though I do surgery and I'm following so many shoulder patients for 6-9 months. But the patients have separate appointments for their managing their work release and their capabilities. The docs call me if they need to know, and I'm just seeing the patients as necessary, depending on their point of recovery. it's really about having educated and interested attendants that are familiar with the work comp system, I think, so they can get the timely appointments. As far as like, you know, a month of physical therapy and then having trouble getting it authorized, that's just part of the system. I wish there was a way to fix that. It would help a lot. As long as the workers know they have to see their attending doctor monthly, and it's not an issue.
Well, I guess that would be my question, is that seeing the attending monthly seems like a burden to the entire system if we know that we have these treatment plans that are going to extend beyond monthly, right? If you see you're attending on the 1st and they say you need X amount of therapy, physical therapy or whatever, a lot of that won't even be initiated. Like you would pop back in on a month and it would be an appointment of, oh, it looks like you got the physical therapy booked and you maybe did a session or two, so we'll see you again in another month. You know, it doesn't seem efficient for our system.
Yeah, it certainly would be more efficient, because that scenario happens constantly in my practice. I'll do surgery on somebody. The first post-op is 10 days later. They don't have any therapy immediately after surgery. At that post-op visit, I give them a physical therapy prescription and a protocol for the physical therapist and a copy of the op note. And then we see them again another month, and quite often they come back, well, I just got one physical therapy visit because it got hung up in the authorization, even though we've had the surgery on the books for 2 or 3 months. I don't know how you can get around that. I'd be highly in favor of any way to streamline that. It'd be better for the system in general, I think.
Thank you.
Can I interject something here? I don't want to take your time, Ron. I'm Jennifer Lawler. I'm at Caremark Comp. I'm the medical director of Caremark Comp, but I'm also in private practice. And I just want to correct one thing before I add my whole 2 cents. But at Caremark, we don't have a 30-day requirement. I know there's a widespread perception that is a requirement, but it's not. And there are not OARs that I'm aware of that require the 30-day follow-up. I do think it's good practice to see the patient, especially if they're on time loss, but that's not something that we enforce.
I have a question for, I think either of you could address that. Thank you for that. Do you feel by having an end date or regular appointments that keeps workers engaged in their treatment?
Usually, yes. There's always some personalities that have pain behavior issues and a little harder to deal with. I wouldn't want to lose track of people if there's not a specific follow-up made, and probably 6 weeks would be a good enough follow-up interval for a lot of my patients, but we've kept it at 30 days, and it keeps us on top of what's going on with the patient. And medically, in my practice with shoulder surgeries, there's occasional people during early post-op get some signs of developing a frozen shoulder, and we want to be aggressive on rehab for that when that does happen. So yeah, I would not be comfortable in my practice not having a specific follow-up schedule for the patients.
Okay, and then I have a follow-up to Matt's questions and scenario. If you had regular scheduled appointments and we're seeing that the system is not moving that patient or the injured worker along, would that be an opportunity for the attending to intervene and help the system process those issues in a timely manner?
Like not moving along, how you mean in the
like if it's taking 60 days, or if the physical therapy appointments aren't getting scheduled, and if there was any kinks in the system, could you help address those?
Yeah. Yeah, a lot of the cases that are prone to having problems like that come with a nurse case manager that helps move it along. And attendings can do the same type of to a point, but as far as getting authorizations for, say, physical therapy twice a week for a month, it has to go through the process to get the patient in. Or I'm not sure how to change that.
No, I understand. I appreciate your thoughts and input on that.
Well, I read through the notes from your last couple. They were you forwarded to me. The other issue that comes up quite frequently in a patient that I've indicated for surgery, but their BMI is over 50, and anesthesia won't put them to sleep for an elective case till they get under 50. And they see them for several times, and as long as they're making progress, then we keep going until we can do surgery. But quite often, 6 months later, nothing's changed. Or the other one is diabetics with an A1C that's over 8. And how does the system deal with that? It seems like that's a problematic area, because if you say, okay, we're going to close your claim and you'll reopen it when your BMI changes or your A1C is acceptable, you close them out, assuming it's permanent disability that hopefully they won't need if they got the proper treatment. So I think that's a difficult problem. The issue that was in your notes was about somebody that wouldn't stop smoking. They probably were getting a fusion or something that is an important thing to issue for the patient to have stopped smoking before their surgery as well.
In those instances, do you continue to see that patient?
Yes, we tried, for instance, when it's just pure weight loss, we thought, well, we're not really weight loss doctors. Let's try to work out something with the place down the street that can work with the patient on weight loss issues. But that really didn't go anywhere in those cases. And similar with A1Cs, but they usually have their primary care doctor that they can work with to get their A1C down. But we see them for usually at least 3 to 4 months, and as long as they're making progress in whatever the number it is that they're trying to get, we'll keep seeing them. It's not a real productive meeting because their A1C is what it is, and that's the only issue on the table until they can get their surgery. And I think meanwhile, they're usually most of them are on full-time loss.
So I have again, I'm not too familiar with how the rules work, but so with those comorbidities, if these are workers who don't have good access to primary care physicians, and so they struggle to manage their chronic illness comorbidities, like in particular their A1C. So in the regarding work comp, they don't get that treatment. They don't have access to that through the work comp. That's only specific. So if you're seeing them for shoulder surgery and their A1C is elevated and they don't have a primary care physician, you aren't able to, or through work comp, they aren't able to work with somebody to get access to the appropriate medications to lower their A1C. And there's some new agents out there that are pretty remarkable for both, lowering the A1C and weight loss, but they're new, so they're incredibly expensive. So for a lot of workers, that they just may not have access to that, and acknowledging those are chronic health conditions, you don't have any ability to kind of refer them to somebody who would manage that through work comp then?
No, it's like, for instance, someone has a cardiac history, and I'm indicating for some kind of surgery, then work comp will pay for a cardiology consult, to clear them for surgery. But if that consult comes up with a treatment that needs to be completed first, that won't be paid in the work comp. So, and some of the patients have private insurance and some don't. So we're sort of stuck if there's not a way to follow through with the indicated treatments.
I think I have one final question. So you have chosen to regularly see your patients in a cadence that makes sense to you. Is there research on the outcomes when a worker regularly seeks treatment on an aiding in recovery that you found?
I don't know. I haven't done a literature search on that. We could look into that. So are the outcomes better with tight management versus surgeon's occasional involvement in post-op? Is that the issue? Yeah. I don't know. It's hard. It's, you know, we've done literature searches on a number of things. Right now we're looking back into platelet-rich plasma injections, and it's really difficult to get work comp only literature or meta-analyses. Usually you get just the opposite. The work comp patients get thrown out of the bunch and you're looking at a treatment option. I'll talk to Yuri and we'll do a literature search on it. It'd be easy to do, see if there's anything out there.
Thank you.
Okay, any other questions? And actually for, we do have a number of MLAC members that are here as well. If you would like to ask questions too, please feel free to do so as well. I'll turn it over to Dr. Lawler next.
Okay. Yeah, I'm actually a member of the MAC, but I have not yet attended since the last couple meetings I think were canceled. But so I think I'm happy to, you know, like I said, add my 2 cents, mostly as a provider who's been practicing in Oregon for 25 years and treating injured workers. So I hope my perspective has something. The one comment about MCO, just to kind of follow up on what Dr. Bowman said, a few things. One is that, you know, the MCO does not require the 30-day, but just by virtue of being involved in reviewing all pre-certification requests, there are more eyes on the case, and there are times where we will initiate reaching out to, you know, to kind of notify the provider that, look, it looks like they haven't followed up in a bit, you know, can your staff reach out and make that happen? So facilitate. But also for when workers are enrolled in Caremark for the post-op, there is some initial authorization of that immediate post-op therapy just to help avoid some of those disjointed gaps in treatment. I think the issue about frequency of visits, I would say right now is a really unusual time. I mean, starting with COVID and whether you call it post-COVID, whatever, it's just really different than all years prior to that. Everything is congested. So it just really wouldn't be very practical for there to be a 30-day limit in most instances. As several of you have mentioned, you know, it might take 2 weeks to get into physical therapy, and that's not necessarily, it might take even longer than that, and that's not necessarily the norm. There's just shortages everywhere you look. It's not just the nursing shortage that we're hearing about, but most offices are, you know, short-staffed as well, anything from reception to medical assistants, and that also extends to the therapy offices as well. So the current snapshot particularly does not lend itself to a 30-day requirement. And I know that was just thrown out there as a suggestion, and it's not the only focus. I do think that, you know, cases vary. There could be somebody where you're just not expecting much movement to happen at all in terms of their progress for a couple of months. And so you intentionally have them come back at 2 months. When I first started in practice, I tried to see my patients every 2 weeks, and that was doable because I wasn't so busy. And there's some benefit for certain diagnoses to seeing with that level of frequency, but other diagnoses, there's just not going to be, to Matt's point, there's not going to be enough of a difference to really accomplish much of anything other than to sort of be a reminder to the injured worker that, you're engaged, you're part of this. So that's where I agree with Dr. Bowman that every 30 days is kind of a nice time frame to make sure that they're still connected to you as part of the treatment team, and keep them engaged, and being reminded of their responsibility in this as well. I think that when patients miss appointments, most offices do have policies in place where they'll reach out and reschedule. And if there are a couple of no-shows in a row, there may also be a policy that, just doesn't allow that patient to be rescheduled further. So those are sort of soft checks and balances that are put in place for all patients, but that would extend to injured workers as well. I know that while the adjusters have the authority to require, mandatory visits, from my perspective, it seems like that is not employed very often. And I've always been sort of curious as to why that is, because even, as the provider, you want to see your patient. And when you have those few, and I do think it's the small percentage that are kind of slippery and they just sort of drift off, they don't come back. It's not really clear what's happening. Did they just find a different attending? And so our office, when something like that is happening, it does become apparent at some point, especially if the second no-show, then, we're making calls or we're making decisions at that point. But that is reactive, not proactive, I understand. In terms of making the work release with a start date and an end date, I confess that I am not very consistent about that, but I do think it's a good strategy to really get the injured worker's attention. However, it creates a lot of difficulty and stress when I know that I can't guarantee I can see the patient in that time frame. So then we find ourselves with, very frantic, stressful messages from the injured worker that, oh my gosh, I'm not going to have my time loss. I need to get this. And of course, the provider is busy as well. So it's stress on their end. So they tend to use that retroactive option and, try to get the worker in or try to extend the same restrictions. So it's a little messy when you put an end date. There are some benefits, but it doesn't work out great. One of my partners has taken to giving a 2-month work release at a time, knowing that in all likelihood, she will see the injured worker before that 2-month mark, but then it overlaps and then she'll just modify it when she sees them. So that's another strategy that she found has worked for her. I think that, what else I want to say? I guess those are my main comments about the frequency of visit. Anybody have questions or further discussion on that?
Just a comment on the different types of practices, like mine is a surgical practice. I spend a lot of time with new patients, but I do a lot of just quick visits, seeing where someone is in their recovery. And it's not hard to work somebody in any certain week. I can get them in, but like Dr. Lawler is a physiatrist, and those are pretty complicated patients, and I imagine you spend quite a bit of time with each one, and the slots may not be there as easily in that type of practice.
Yeah, I think that's exactly what happens. We'll schedule an hour for a new patient typically, and 20 to 30 minutes for a follow-up. So there's just not the time in the day to fit them in. Plus all those staffing issues that I mentioned. It took us 7 months to hire a medical assistant, for example. And it's really unusual times. I think the other topic that that was brought up by Dr. Bowman about how to deal with these cases that just kind of dead end. They're not resolved, but they're stalled out because of an A1C or pregnancy or, you know, some situation. And there have been times for injured workers that are enrolled in the MCO that we've said, just, you know, can you declare them medically stationary, knowing that it will be reopened at some future point if and when they accomplish these goals. Then it comes down to the difficult, you know, sort of educated best projection of their current limitations and sort of parsing them out to whether they are due to the accepted condition or not. It's never easy. It's never pretty, but you know, there are scenarios where that I have also seen for for the A1C being elevated. In most instances, they do have medical providers, and they're working with their provider, or we get an endocrinologist authorized by the adjuster so that they can get a little more guidance to help move things forward. But it is an individual case by case situation, I think. There's no one size fits all for those. And then I guess another area that I just wanted to speak to was about continuity of care as pertains to the use of physician assistants. And I, you know, I feel like I have sort of mixed thoughts about that. I do think the training is different. While there are certainly physician assistants who have an amazing amount of experience, including in work comp, I think it's very mixed. And I think for that reason, you know, I have some hesitation about, you know, completely changing the type category, but I would also say that the access to care is a very real problem, especially in rural areas. And um, I have to believe that trends are moving towards primary care being predominantly physician assistant and nurse practitioners. So um, those are just some perspectives I wanted to share. I think that the challenge for me is, especially in my role at Caremark, when I'm reviewing records and there's an office that has a specialist, typically a surgeon, and a PA, and there's alternating appointments, I find that to be more problematic than anything else, because even though they're sharing the same record, there are differences of opinion in how things go forward. And instead of being a linear course, it tends to have a lot more zigs and zags. And I'm not sure why that is, but I think it's just because most practices that do employ PAs have a somewhat loose supervision structure. I mean, sure, it meets the criteria, but I that's just my impression from reading the records. And so I have some concerns about that model more than I would have concerns about having PAs play a role early on. I think that one of the most important things in the Oregon work comp is that very clear attending physician or attending provider responsibilities, and that everything flows back through them. I think that's just essential. And when that falls apart, it gets really difficult to manage the care. Most specialists that I refer patients to are not interested in becoming the attending at all. And in fact, that is a barrier to care, especially for continuity. There are more and more providers who are saying no to work comp, especially if the claim is older than, they'll either say 6 months, 9 months, or 12 months. And I guess that would be a potential, um, you know, reason why making sure that care is happening up front so that referrals can be initiated sooner in the claim. Um, Whatever it takes to make that happen is important, because they're pretty rigid on those timelines, and then there's nobody to turn to. So part of my comments about the role of PAs in work comp and just, you know, these access to care issues also would raise the question of, you know, what specifically is influencing providers to step away from work comp. And I think surveying providers out there is it's probably overdue. is it a reflection of all of the burdens that have increased on providers? I mean, we get notifications from pharmacists now about medications that we know the patient is on, and then we get the Optum care, and then we get it's just, there's an unbelievable avalanche of busy work. So I don't know if that's a big factor. I don't know if it's that the reimbursement hasn't kept pace. I think there are a number of factors, but it's a question that probably should be addressed at the higher levels so that the whole system can continue to, function.
Yeah, there was an article, study done in, it's probably 30 years ago now, in the Journal of Bone and Joint Surgery on the administrative costs in an orthopedic office, work comp versus normal regular insurance. And it was about 40% increased cost in just the paperwork that was involved with the different steps that are involved. And I think that, coupled with not much change in reimbursement for a long time, leads a lot of the providers that have been in the work comp to just drop it because they don't want the hassle. It's not worth it.
Yeah, and I mean, it's anecdotal, but I can say that in speaking to different physiatrists, and rehab, we're one of the specialties that is probably most aligned and most appropriate to see people who've sustained injuries on the job. There's, I would say, at least 50% have reduced their work comp patient caseload, and also, considered just kind of reducing it further. So that's not a good sign. But I think that some of it is the contentiousness that can come along with injured workers. But I think there's just a lot of burden in healthcare in general. And when providers are given a choice, I'm going to exit out of this subcategory, work comp kind of is carved out because it's the one area where maybe they can actually make that choice. So you don't really have a choice in other areas. I certainly see that amongst employed providers. They're given the choice to treat injured workers or not. And for the most part, they choose not. So I bring this subject up primarily because I think that in contemplating solutions to some of these challenges, I would just be mindful of making sure you have adequate input from, the provider base, because there's, it's a shifting landscape right now.
This is Matt. I just had one question. You said when employed providers, so they aren't, those folks tend not to be as tied to the reimbursement end, right? So they kind of that's less of an influence. So they would be choosing not to work with work comp patients for maybe different reasons than the administrative burden that you've identified.
Exactly that. Yeah. I think, they're indirectly affected because they may have a productivity requirement, and they may have other timelines that are pretty aggressive sometimes for finishing all paperwork. And so when you look at the time involvement for injured workers and then the paperwork burden, I think those are factors. And I think it's also just, like I said, when you're given a choice, human nature, wants to take the path of lesser resistance, I can say.
Thank you.
You're welcome. Any other questions or comments?
Don't see any. Thanks, Dr. Lawler. Lon, good morning.
Good morning. Thank you for having me. Members of the committee, my name is Lon Holston. I am a member of the Medical Advisory Committee, and I speak today for myself and not the committee, and as an injured worker, a past injured worker. The Oregon workers' compensation system can be challenging at best for injured workers, and this becomes problematic for those workers who are language challenged Injured workers, for the most part, strive to get back to work and have their life normal again. I represented workers for 41 years, and my employment background consists of production, manufacturing, residential, commercial, and industrial construction. I was also a lobbyist at the legislature, MLAC member and co-chair, and I currently sit on the Medical Advisory Committee. I live in the Portland area, so I have good geographical knowledge of providers that are out there. I've experienced as an injured worker both inside and outside MCOs and that environment. I was enrolled in an MCO in 2012, and this enrollment continued until last year. As an injured worker, I must trust my medical provider and attending physician to have my best interests at heart, and I rely on that physician to manage my treatment and get me back to work as soon as possible. This is the same case for most injured workers. Most injured workers show up for all their scheduled appointments, whether it's with the physician, physical therapy, or diagnostics, in my experience. While enrolled in the MCO in 2012, I had my first surgery, and my medical provider wanted me to have physical therapy within a short amount of time. The request was turned into the MCO for the approval process. Post-surgery, I saw my physician a couple of times for checkup and let him know that we had not had the approval for the physical therapy as of yet. After that, I saw my physician again 30 days after surgery, and the physical therapy had not been approved at that point. I was having serious mobility issues with my shoulder due to tissue freezing in my shoulder. It wasn't until 6 weeks post-surgery did the approval arrive, and the letter was backdated for several weeks. Now, I don't know whether it sat in an outbox or what happened with that process, but things do happen. For shoulder surgeries, it's not uncommon to have a patient get into physical surgery or physical therapy soon after surgery just because of the mobility issues. So I've also run into problems with approvals for medical devices pre-surgery. And one particular case, I had an ice jacket in the first surgery, and it actually helped me when I had a reaction to the pain medications and had to drop them. So I did a shoulder surgery with no pain meds and an ice jacket. And as long as I didn't move, life was good. But that particular ice jacket was then denied in the second 2 surgeries because I had a total of 3 surgeries on my shoulder. So I have to tell you that there is complications that are out there that happened on a regular basis. Now, I'm not here to trash MCOs. I think the MCOs do bring value to the workers' compensation system and help manage some of the claims. I do feel, however, that for me, who's been in workers' compensation policy for a long time, I was able to pretty much fend for myself, including at a time when I could not find providers, and I called the MCO office and they were able to give me a list of providers for my 3rd surgery. And I thank them for that, and they were very efficient with it. If we're talking about these guidelines, and we're talking about seeing patients and how long they're being seen, I spent plenty of time going to my doctors and physical therapies. I went 3 times a week for 18 months. And at one point I had to have my wife, since I couldn't drive for 90 days, have her drive me to these physical therapies and to the doctor visits. It isn't easy on an injured worker trying to make all these appointments. Now, I do understand that things are a little different now post-COVID, and that there is issues trying to schedule and trying to make things happen. But these hard dates are not necessarily what I would call productive. So if we talk about what the real issue is, in my mind, there's a pretty small pool of folks who are difficult to deal with, and as they said, and I heard the term also, dodging doctors or doctor dodging. And I don't think that it's productive for us to loop all of the workers who are trying to get back to work and be productive with their employers into that same little pool. And if I'm the insurance industry and I'm looking at House Bill 4138, insurers, they insure against risk of injury. Premium rates are set on that exposure of risks. And if we are to believe the NCCI report, then there is a certain amount of exposure that I know would give insurers heartburn. I mean, if you've got that 45-day look back, that's got to be pretty scary when your premium rates were set and now you have the look back and they're not included. That risk is not included in this. And I see it as a real issue. So I have seen proposals for punitive measures and that would lump all workers in the same pool. But if the potential exposure of the insurance providers is that high, maybe we should mitigate this exposure through other means. I would propose we look at solutions that include incentives and motivation. The incentives and motivation go hand in hand, and some of the solutions to be looked at could include modified job offers for meaningful employment with employers that are approved by the physician. Appointments with the physician could be scheduled before the injured worker leaves the physician's office. And I agree there with Dr. Bowman. It was very effective in his office to make sure that we had the appointment we needed. And diagnostic and physical therapy appointments could be made directly from the doctor's office with those particular providers, which ensures that the doctor, the injured worker, and the physical therapist are all on the same page when it comes to appointments. Third and lastly, I would say, and I would just throw this out there, that there should be some kind of compensation for completed physician appointments. Now, I know there's some of you out there rolling your eyes, but please hear me out. Most of us have cell phones these days, and the cell phones is a calendar that we normally schedule things to make sure we don't miss appointments. When my appointment is made with a physician, it's complete and on that handheld device. When I was in the appointment, I was handed a slip of paper to give to the front desk staff for scheduling appointments and physical therapy at that point. It's all on the same page. It was simple then to see what the doctor wanted and when he wanted to see me again and how many physical appointments I needed to complete per week. A quick phone call to the physical therapy office would then fill in the blank for the visits. And at this point, the physician's office and the injured worker have the appointment schedules in hand. Compensation for completed positions or appointments would not happen on the front end, but could accumulate over time. And a certain dollar amount attached to each doctor visit would then become payable after medically stationary. This would serve as a incentive and motivation, especially for folks who are language challenged, or maybe they are getting a little sloppy, or if they're a low wage worker. This would all be incentives to say, gee whiz, go to the doctor's appointment, get treated, get yourself back in shape and get back on the job. So you can mitigate your exposure with smaller dollar amounts to be able to control your costs with the compensation proposal. This would create knowledge for the injured worker in the system, especially those who are challenged. So lastly, the approved light duty positions speak for themselves. These could be fashioned in numerous ways, and I'm sure employers have creative ways of making sure that there is meaningful employment for these workers to help them move their business forward. I know this is a tough question, but when I looked at that particular House bill, it certainly set my alarm bells off also. Even representing injured workers, there's an exposure out there that nobody counted on. And now it's here, so to speak. And I see some of this on time loss and limiting every 30 days. I know that was just thrown out there is problematic. So I would think that or what I would like to see is some kind of incentive program, if that is something the committee would take a look at. I'm open for any questions if somebody would have one out there. I thought so. Thank you for having me today.
Thank you. This is Matt. You did perk my interest around the incentive. And I'd be interested to hear from maybe some of the physicians today. I did a brief literature review on like patient compliance and within chronic illness. So I do want to be cautious not to extrapolate that to injured workers, but there was a fair amount of literature out there that supports incentivizing compliance with like chronic illness, antibiotic therapies to prevent the, creating resistant microorganisms. And it wasn't all just financial, there were social supports, as Lon mentioned, around just getting to the appointments and things like that and building those structures. So I'm curious with the physicians who are experts in work comp, if you're aware of any studies or any kind of consideration for that incentivizing the continuation or that continuity of care, and also being mindful of your all time as physicians and if you have to go get it. So thank you.
Yeah, I'm not aware of any literature on that specifically in orthopedics. I mean, there's literature on rehab from certain procedures and certain diagnoses, but I'm not sure how you would find that.
Thank you.
Yeah.
Any other questions for Lon or Dr. Bowman? Okay. Thank you to both of you for taking the time to schedule. Oh, Lon, do you have anything else to add?
Thank you very much for having me.
Thank you for having me too.
Thank you.
Thank you.
Okay, I'm looking through the various squares of Zoom to see if there's any other providers or stakeholders that wanted to provide input, some carry over from our last meeting. If so, please raise your hand or so 1 more minute, a second or so. I don't see anyone. I'm also going to check my email just to be sure in case there's somebody that cannot on the phone. Nope, I don't have anything there either. So do we, I'm turning to Matt, Sarah, do we want to go to committee discussion next?
Yeah.
Okay.
So I believe we're waiting on some research findings and just kind of checking in on seeing when we feel that we can get those.
That's a good question. I know that obviously it's not ready for today. I will check with staff to see that. I guess my other question to both of you, and I can check with the co-chairs as well, is now that we've had, different, 2 meetings with input from folks in the various communities, provider groups and such, that my thought for myself for next steps is to kind of synthesize what's been mentioned. Also from the first meeting, the different issues, obstacles, items that have that came up as well, to kind of just put them into buckets and just kind of put everything into like one resource for both of you to look at, and also the other MLAC members as well on that. My question to both of you, Matt and Sarah, is so for example, with the MCO groups, we've heard directly from 2 of the 4. Would you like me to do another round of asking these questions and have them in writing so that you have information from all 4 MCOs for your deliberation?
There may be benefit to that. I think just to see, because I think now we've kind of heard that maybe a little bit different from the 2 that we've heard from. So
Mhm.
I think
Okay.
that would be in support of that.
Okay. That works. Another thing that I thought too, from particularly from this morning's conversation, is also looking at the comparison, because I know there was mention of whether if it's an MCO practice, if it's not in statute or in WCD administrative rule, kind of clarifying that and having that on, on the resource document as well, of like what's currently required, what isn't, what is via rule, and what is practice. Just thinking, building the plane as I'm flying it, I guess, in regards to what this document would look like.
And so that would delineate, this is the OAR
Yep.
and this is and this is like a specific to just that agency.
Yeah,
Yes.
and then like specific to the MCOs, like if there's particular, like in, as information is put together and compared, what's the commonalities between all four, what differ, things like that, what differentiates. So that way they can help you too, in deliberations there. I'm also guessing that there will likely to also be a need for current counts of different provider groups. For example, the number of physician assistants broken out. Also, I think nurse practitioners were mentioned, probably the other, like the type A, type B physicians, I guess, will probably be the most useful, I would guess, and nurse practitioners.
I don't think that was necessarily in our scope.
Yeah.
Right. So I don't know, Sarah, do you agree that we weren't set out to analyze that part of who's going to be declared a type A and whatnot? Feels like that would be kind of outside of the scope of this subcommittee. I'm not sure though.
I agree. And Matt, we're going to talk about, if we had time to, maybe I'm going to pull it up, review our problem statement to make sure we're covering everything.
Yes.
So I'm going to personally pull it up.
Okay. And I will put it in I will put the charge in the chat as well for those, for all of us.
But in terms of research, Teresa,
Mhm.
I heard Dr. Bowman say that they were going to look at it, but maybe you could follow up with outcomes.
Okay.
When a worker regularly sees a provider.
Mhm.
So I would add that in addition to, AKA best practices, what they're finding out there. Yeah, but I agree with Matt that type A and type B providers is not in our scope.
Okay.
Reading it, when workers who are off work or on modified work maintain regular treatment with their attending physician, they have more successful outcomes with their rehabilitation or return to work. But when a worker and their attending physician are not maintaining regular contact or treatment, rehabilitation or return to work can be delayed while worker receives time loss benefits. The purpose of the subcommittee is to explore solutions so that all workers are able to remain connected with their provider and minimize gaps or delays in treatment when they're off work or return to modified work.
Okay.
So I propose that we meet when we can have our answers to the research questions and what other states are doing.
Okay.
And so I think that's on you, Teresa, when you feel that I don't mean it that way.
No, I know what
just,
you mean.
Just when you feel that is, that timeline can be reached.
Sure. That makes sense.
And that might be a time for any lingering testimony. I know we haven't heard from the small business ombuds office, or any businesses might want to weigh in at some point and see what the impact is on them.
Yep, no, that makes sense. And that was my thoughts too, of getting everything synthesized into one resource, is seeing what gaps of information both of you need for me to do follow up on with various organizations, or again, like with Providence and Kaiser MCO, for example, on that. And so I'm guessing, and I will, this is of course the first question I'll ask the department staff that's tasked with the various research aspects, is that the next meeting for the full committee is on October 20th, and so that is in the co-chairs document that's the status report, or the next opportunity for a status report of the subcommittee.
Right.
So I
So
think
I,
that we'll be
I would like
get
to
them through
meet
that.
prior to that, so
Of
we have
course.
something to report, and I think Matt's on the same page with that one, that, so if we could find a time frame, even mid-October would
Okay.
be helpful.
Okay. We will work on that and get that out as quickly as possible. We'll run by both of you, of course, before we publish get the agenda finalized and get sent out on that. I think the other thing too is that there may be also some subsequent information from stakeholders that may possibly come up on the 20th. I've not had a chance to talk to the co-chairs yet, but my thought, it's either going to be the October or November meeting. It will be the kickoff for stakeholders, and this includes WCD, to talk about their legislative concepts for the 2023 session. So there may be some information that can be gleaned from that as well, just from people's presentations. Not that I would seek such, but there might be some information.
Well, Teresa, we're charged with having a full recommendation at the November 10th
Yes.
meeting.
Yes.
So
Yes. So I'm under the presumption that it is the task of myself and staff to get as much done as far as research for first review by our next scheduled subcommittee date, which will be before October 20th. So early to mid-October at the absolute latest.
Yeah, that sounds
Okay.
Sounds appropriate to me.
Okay.
yeah, I like the synthesis document. I think that'll be helpful to put it all in one format, so we
Okay.
can review it.
And I will do
And
a
then find
skeleton.
the gaps too.
Yep, and I'll do a skeleton, so to make sure for both of you that I'm on the right track in regards to like how you want it to look and what's, about that. Because again, my goal, and this is just for myself, I like things in which they're laid out, but not so in depth that, you have to read something with like a 9 point, with a magnifying glass, because there's so much there. So we'll seek balance there. Okay. And I think if there's anything else, I think I've got a couple of emails that I may forward to both of you in regards to other thoughts on information to obtain. Although I think some of it may actually be more long-term versus short-term. For example, like Dr. Lawler's thought of a survey of provider groups that may be more of a long-term issue.
That's something to kick back to Mac as well.
Yep, that too. Yeah, there's other ways of doing it. So yeah, I mean, it could be something that's mentioned that can be a part of the thoughts of the subcommittee's final recommendations, but I'm not sure if it could be completed in time to meet the November.
No, nor is it in our scope. I think
Exactly.
that's a larger systemic
Yep.
recommendation that is out of our scope.
Agreed. And I think that's one of the things I will do too in the synthesis is those ideas and just thinking about short-term, long-term, that sort of stuff as well to keep in mind. So I think I've made my to-do list for the next couple of weeks. Is there anything else that both of you need, or since we have stakeholders here in the virtual room, to ask questions?
We welcome stakeholder input. And speaking for myself, but hopefully for Matt as well. So we definitely want to hear from you.
Let's see. Hi, this is Dave Barenberg. And one thing that I know was mentioned was doing a literature search on the issues of, is there information tied to connections to care with recovery? And I don't know if that's something that should be undertaken, something that might be on the list of data that you might want to take a look at and to be researched.
I'm sorry, Dave, you're suggesting that you would like us to take on
Well,
that?
it's yeah, or I don't know if the division or someone, or I mean, we can also take a look, but it just seemed like that might be useful for doing a literature search to see if there's any data that can regarding that issue.
And I'm unclear, but did Dr. Bowman say that he was going to look into that with somebody?
So maybe
Yeah,
Teresa follow up to make sure that gets doesn't fall off, or someone does it. If they can't do it, someone undertakes it. Because I believe that is helpful information for us at this subcommittee level.
Yes, and I believe Dr. Bowman did charge that with MAC staff, so it is on their list. The MAC staff is here in the room.
Thank you.
Anyone else want to provide inputs? Okay. I think that ends everything. Again, to those in the audience, we will we're quickly on getting the next dates scheduled and published via Gov Delivery. In the meantime, if there's any questions that you stakeholders, if you have about the subcommittee last minute input that you want to provide for the resource document, please feel free to reach out to me. That'd be very helpful. And with that, I think, Matt, Sarah, if there's anything else, I think we're done for the day.
No, just thank you very much. We appreciate everyone's time and efforts and energy into this subcommittee.
Yep. Thank you very much.
Okay, great. Thanks, everybody. Have a good day.
Bye-bye.